Thank you for joining us today for the Geriatric Grand Rounds program. This program is provided by the Michigan Center for Rural Health in cooperation with MSU College of Human Medicine and the MSU College of Nursing. Before we begin, just a few reminders. Please keep your mic muted until the Q&A component at the end of the presentation. Please remember to mute your mic after you have asked your question so the signal is clear and the presenter can answer your question. Handouts are located on our website at www.mcrh.msu.edu. Click on the education link across the top, scroll down, find today's date, and there you will find the presentation, attendance forms, and the evaluation link. Continuing education is available for physicians, nurses, and social workers. Each healthcare discipline has their own attendance form or sign-in form, and everyone fills out the same evaluation except for physicians who have their own evaluation and attendance form. The attendance form and sign-in forms need to be emailed, faxed, or mailed into the Michigan Center for Rural Health office. Sign-in forms must be signed by a proctor, and these all must be filled out and returned to our office, or you will not receive credit. Nursing attendance forms need to be filled out and signed by hand, and the evaluations all must be completed online. Physicians, please note, in order to obtain your certificate, you must do this through the new CME portal. If you have questions, please email me if you have questions on how to do this. The steps are also on our website. Please complete these forms within 2 weeks or by October 18th. Our speaker today indicates no conflict of interest, and the planning committee did not have any conflicts. There is no commercial support for this program. With that, I am pleased to introduce Dr. Mark Ensberg, who will be speaking on competency versus capacity, decision-making capacity. With that, I'll hand it over to Dr. Ensberg.
Good afternoon, everyone. I work at the Senior Health Center in Lansing and going to present this from the perspective of the outpatient older adult. Most of my patients are 75 years of age or older. I also do some work in a subacute rehab unit and in long-term care. So that's going to be my perspective today. There are really 4 objectives for this presentation. First, I'd like to define the terms decision-making capacity and competency and contrast those 2 terms. Secondly, I'm going to discuss some barriers to your assessing decision-making capacity. Thirdly, highlight some observations that you can make that might suggest that a person does have impaired decision-making capacity. And then finally, list the items that need to be documented to support your assessment of decision-making capacity. And to make things easy to remember, each of them starts with the letter C. First, let's start with defining some terms. Decision-making capacity. Decision-making capacity is really a determination made by healthcare professionals. And it really is a clinical assessment of a person's ability to make specific decisions in specific situations. Often the issue is raised because there might be concerns about a patient's ability to make a medical decision. There might be concerns about the living situation or how they're spending their money. So as a healthcare professional, you're called in with this specific situation for a decision. Contrast that to competency. Competency is a legal term. Lack of competency is really determined by the court and often arises when there's disagreement between family and the provider as to whether or not a person is able to make decisions. There might be disagreements regarding decisions being made. And then occasionally, if a person is highly impaired and permanently impaired, such as someone with a developmental disability, the courts will step in and determine lack of competency and often appoint a guardian. If the concerns are primarily financial, the court may appoint a conservator to manage the money. Court proceedings, though, can be long, expensive, emotionally challenging, and hopefully today you'll leave with some thoughts as to observations that you can make in assessing decision-making capacity. First, I'd like to talk about different areas where decisions are made in our healthcare practices. Patients make decisions about who they would want to be a power of attorney for health care. There are more mundane decisions such as managing your medicines, and you might be called upon to recommend that a person use a pill box or that someone had managed their medicines for them. There are decisions that people make about their medical care, permission to get tests or decisions about treatments. People refuse care. There are issues related to living safely at home and whether or not a person is able to provide their self-care. And then finally, finances. These will be the areas that I'll be focusing on today. There are other decisions such as driving a car, sexual consent, the ability to transact business, voting, and making a will that we'll not address today. In our Western culture, people are assumed to have the capacity to make decisions until proven otherwise. And I'll just highlight that word assumed. Very often, human nature being human nature, as long as we agree with the decision that a person is making, we tend to assume that they have decision-making capacity. And very often, decision-making capacity is called into question if there's an interaction with which you're uncomfortable, such as refusal of treatment, decisions that require high risk, if there's concerns about a living situation, or concerns about abuse or neglect. One that comes to mind that I saw recently was a post-operative patient that I was seeing in the rehab unit. She seemed fairly intact, developed symptoms of a pulmonary embolism, was hypoxic, having chest pain, but refusing to go to the hospital. That certainly raised in my mind the question of whether or not she was capable of making decisions, and something that we had to address on the spot. Or you might be working with an older patient and their family, doing your best to keep them at home. It might be a person who's capable of making decisions and choosing to live in situations that you or I might not choose to live in. Sometimes they'll show up in the emergency room, and the emergency room will certainly question that person's ability to make decisions, and sometimes will even question the doctor that's taking care of them without necessarily knowing the background information. But in general, people have a right to make bad decisions. And again, hopefully at the conclusion of today's presentation, you'll be able to document the evidence to support a person's ability to make bad decisions. I mentioned the assumptions. We really should at times document a person's capacity to make decisions to which we agree. So for example, if a person is going to be having a high-risk surgery, or if poor outcomes are expected, we get informed consent for that. And there are really three aspects to informed consent. First, a person needed to be provided with adequate information. The decision needs to be free from coercion. And finally, they have to have medical decision-making capacity. So these are situations which we should be documenting that a person is able to make medical decisions. I do a lot of work with community mental health and see several of their patients in the office. And every now and then I'll call community mental health and ask them, now who's making decisions here for Ruby, who I'm seeing today? And community mental health will politely remind me that odd behavior doesn't necessarily mean that a person's decision-making capacity is impaired. I think of a patient, Ruby, that I saw, that when she would come to the office, she would bring 3 grocery bags full of her belongings and food, because if she left it at home, she was fearful that people would poison it. yet she was felt to be fully capable of making her own medical decisions. So again, odd behavior doesn't necessarily mean that a person has impaired decision-making capacity. Another patient, Dolores, came into the clinic one day with cotton stuffed in her nose. She was fearful that people at the adult foster care home were going to poison her, yet even she was capable of making medical decisions. Just the mere presence of a psychiatric disorder does not mean that a person lacks decision-making capacity. A patient by the name of Lucille, who had paranoid schizophrenia, a very highly intelligent lady, she learned that she had triple-negative breast cancer and came to our office with very good information from the internet about triple-negative breast cancer, asking me questions that I could not answer. And again, despite her odd behaviors at times, she was really capable of making her own medical decisions. It took a long time and it took patience. A diagnosis of dementia also does not automatically mean that a person is not capable of making decisions. You really need to look at the complexity of the decision being made, and a person with mild dementia can make some, or at least participate in some of the more simple decisions. What I'd like to suggest that in thinking about decision-making capacity, you remember three words that begin with the letter C: communication, culture, choices, circumstances, consequences, and consistency. And what I'd hope is that by remembering these, you're going to first avoid errors in determining that someone is not capable of making decisions when in reality they are. I'm hopeful that you identify persons at risk for impaired decision making and that it will help with your documentation. I'd like to first start by talking about the first two C's above the first line there. Communication and culture are really potential barriers to your ability to assess decision-making capacity. To make a decision, really three things need to happen. You need to hear or read or receive information. You need to process that information in your brain and express a choice. And problems with communication that greatly affect your ability to receive information or to express a choice can make it difficult to evaluate decision making. An obvious one would be a person that's hard of hearing. And I'll occasionally see a person in the emergency room who appears very confused. Get them up to a quiet room where you can communicate with them and they're quite intact. The problem was difficulty hearing. I also think of my mother-in-law, who is very, very proud, but very, very hard of hearing, and did not acknowledge this to anyone. At various times, she was thought to be demented. She was thought to be having some psychiatric illness. Really, she was just very hard of hearing, would not admit it, and would often give wrong or inappropriate answers to questions that she couldn't hear. Looking at the ability to express a choice, some people have had a stroke. They might have an expressive aphasia where they really can't say much of anything, or a word salad aphasia where they speak just gibberish. Or there's something called a locked-in syndrome, which is a brainstem stroke where the only thing the person can do is blink their eyes voluntarily. These would be very difficult situations, but situations where people might be empowered to make their own decisions. And I leave a reference there, the Cambridge Quarterly of Healthcare Ethics, because this discussion is a bit beyond the scope today. What I'd really like to focus on are hearing impairments, language barriers, and health literacy as barriers to effective communication. This picture is from Dr. Seuss's book, You're Only Old Once, and it's really a good depiction of presbycusis, which is the most common hearing problem seen in older persons. With presbycusis, you tend to lose the higher frequencies or the higher pitches. Those are the S's, the T's and the K's that help us distinguish speech. So an older person with presbycusis might tell you, I can hear things, I just don't understand them. What this picture shows, the bell or the clock represents the low tones, which an older person with presbycusis can hear, and also speaks to the importance of eliminating background noise, which can make it very difficult to communicate. Just some general tips in communicating with people, older people in general, would be to address using the last name, face the person at eye level, speak clearly in lower tones, avoid shouting, because when you shout, you tend to raise the pitch of your voice. Rather, you should lower the pitch of your voice, and then don't rush with communication. All those things can facilitate communication in a person that's hard of hearing. Occasionally, we may need to assess a person for whom English is the second language. And really, there's a lot of prevention that can be done to avoid communication issues with people who speak English as a second language. I think when they first become a part of your practice, that's really the time to find out what the person's primary language is, what language they feel most comfortable speaking, can they read and write English, make some decisions about whether an interpreter is needed, and whether they have someone at home who could help understand written directions. Remember that in a crisis, people will often revert to their primary language and find it more difficult to communicate in English. And you also need to think about how the disease affects their ability to communicate in a second language. For example, I see a lot of people with dementia who speak two languages, and as the dementia progresses, often they lose their skills in an acquired language and revert more to their primary language. Delirium or acute confusion could also certainly affect a person's ability to use a second language. I think it's really best to err on the side of using an interpreter. I think of a patient that I saw recently who has a mild dementia. She was good of hearing, but her daughter was totally deaf. And so intermittently when I meet with them, we hire a sign language interpreter. And although at other times we communicate by writing, I've always been really impressed and astounded by the richness of the information that you obtain when you use a sign language interpreter, and we really should be doing more of this. Sometimes using the telephone interpretation services can be a bit of a challenge. I have a Hispanic gentleman who speaks Spanish primarily. The issue with him is that he has a dysarthria or kind of a slurred speech, so our efforts to use the telephone communication system don't work real well, and then we need to either hire an interpreter to come into the clinic or work with the son. Usually it's best to avoid using family members and to hire interpreters. Finally, a few comments on health literacy and how that might affect communication. Even people who read well and are comfortable with numbers can face health literacy issues if they're not familiar with medical terms, if they don't know how their bodies work, or when you're using statistics or trying to explain things with numbers. Often people can be scared and confused, or their care can be quite complicated. I think our goal should really be to empower people with low health literacy to participate in decision making by changing how we communicate with them, rather than making the mistaken assumption that they're not capable of making decisions. I'd like to move on to the second barrier that we were going to talk about, which is that of culture. And I'm going to acknowledge up front that I'm not an expert with different cultures, but I do believe that part of addressing second cultures is recognizing your own cultural biases and acknowledging your own limitations. So I work in a Western culture. our Western culture really values the independence and individual autonomy. Not all cultures value independence and autonomy of the individual as much as our culture does. On this slides are two excellent references. The first is Doorway Thoughts. It's a one-page summary of different cultures that's really designed to read before you walk in a room to see someone, and it kind of gives an overview of the Hispanic culture or the Latino culture. It can be helpful, but it's really important to avoid generalizations and not make assumptions, and also to look at other resources that you might have, such as faith leaders, social workers, or others that can help in these situations. Also, there's a website at the Stanford School of Medicine on ethnogeriatrics that also provides some very excellent information about dealing with people of different cultures. I think the bottom line with both of these, though, are not to make assumptions, to avoid generalizations, really to listen first and keep an open mind. In dealing with people of different cultures, again, dealing with this early on can be helpful. When a person first enters your practice, some questions to think about might be who lives in your household, asking them if there's someone who they would want to be involved in their healthcare decisions, and asking them how they would want them involved. Sometimes we don't have the liberty of doing this at our convenience and there's a crisis, and then it's really in the time of a crisis working with the patient, their family, faith leaders, your social work to address the cultural issues. What I'd like to do is to just give some examples from Doorway Thoughts, things that I've seen in my own practice, again, keeping in mind to avoid making assumptions and generalizations. First, I'd like to tell you about Clarence, who is African American, and I've been working with he and his wife to encourage them to fill out a durable power of attorney for health affairs. Well, they were really reluctant to do that. We got talking about family, and they made it clear that their preference to make decisions would be their adopted daughter rather than their son, and they gave me very clear reasons why. But it was interesting in talking with them, this daughter was not legally adopted. She was a person that had been part of their family for 30 years, a very good friend. This is known as fictive kin. And again, in this family, they had a close relationship with her. Their preference was not the son, and it was really a challenge explaining to them how they could protect their autonomy by filling out a power of attorney that would empower her to make decisions in that situation. With American Indian older adults, again, avoiding generalizations, it's very important to look at the customs and of the individual tribes, but very often in the American Indian culture, decisions are made in a family unit, and that might include people outside the immediate nuclear family, might include specific kinsmen, perhaps a mother's brother or paternal aunts. Just being open-minded and listening. In looking at the Arab American culture, one really needs to think about the process of acculturation and how first generation, second generation, and third generation may differ. Again, listening, being open-minded, but in some instances, particularly in the first generation immigrants, men in the American Arab family may have more authority with regard to medical decisions than women. Looking at Asian Indian American older adults, Asian Indian tends to emphasize interconnectedness and downplays individualism. Important decisions are often made after consulting with family, or they may consult a medical professional within the family or a friend. And then the last example might be Chinese American older adults. And again, this very much depends on the degree of acculturation, but in general, Chinese culture emphasizes and values family involvement and group decision-making. Chinese may also be reluctant to talk about cancer or end-of-life issues for fear that talking about it might cause it to occur. Just some examples of how communication and culture might be potential barriers to your assessment of decision-making capacity. Next, I'd like to move on to the next 3 C's, which are choices, circumstances, and consequences. These 3 C's really get down to the ability to understand, appreciate, and reason. And I'd just like to comment that there's a difference between understanding your choices and facts and appreciating it. One can understand the details, but appreciating is knowing that the situation applies to me as a patient and that the good and bad things are going to affect me as a patient, not just abstract things that can happen to people. So it's really applying that to the individual itself. First, I mentioned earlier that decision-making capacity, we're looking at specific decisions in specific situations. Some of those specific decisions are the choices that you have to make, and they might relate to medical situations, living situations, or financial. In assessing decision-making capacity, you really need to look at the decision that's being made and the complexity of that decision. So, for example, a decision to have blood drawn is relatively simple and straightforward, and someone with advanced dementia could make that decision. Decisions about chemotherapy or whether or not to have a colonoscopy for rectal bleeding are a little bit more complicated and might require a little bit more thought process and be more complicated. Finally, something like bypass surgery or maybe joint in place replacement in someone that's already quite impaired, those are quite difficult decisions, and someone who might be able to make more simple medical decisions might not really be capable of making more complex decisions. Related to living situations, situations of self-neglect where the person appears to be able to make their own decisions are always very complicated. Financial decisions, it's one thing to use a debit card or to manage your own finances, but more complicated decisions such as doing your taxes or running a business might be situations where a person might be able to make more simple decisions, but not able to participate in more complex decisions. The next C is the circumstances, and these are really the facts related to the person's situation. Related to medical circumstances, if you have spent some time explaining a person's medical condition to them, the teach-back method can be a good method for assessing their understanding of the circumstances. Ask them, tell me in your own words what I have told you about your condition. I deal a lot with living situations on the rehab unit, and I'll often assess their understanding of their home situation by asking them to tell me a little bit about your home. What is most difficult for you at home? What were you having problems with? And if a person is able to give me specific examples of things that have been difficult, I'm more comfortable. If they tell me that everything was going just fine, I'm less comfortable and explore the topic further. Finally, looking at assessing a person's financial circumstances, asking questions such as, does someone help you manage your money day to day? Do you worry about financial decisions that you make? Have you given power of attorney to someone? Are examples of questions that you can use to assess someone's circumstances. And I've given you a website there that's really an excellent resource on assessing a person's financial circumstances with some very good brochures, checklists, and information there. Really, the key to assess a person's medical decision-making is their ability to reason or to understand the consequences of decisions that they do make. And again, remember, understanding is not the same as appreciation. It's important that they understand that this situation applies to them. So really looking at their ability to understand, appreciate, and reason. When they've made a decision, asking them, tell me, how did you come to make this decision? Or if they're refusing to have a particular treatment, to ask them why they chose not to have this treatment and kind of get their sense for their understanding of the good and the bad, the benefits and the risks of the treatment that you've talked with them about. I always think about Ruby, a patient that I saw several years ago in the hospital. She was a rather odd person, we'll say, and just before I went in the room, a physical therapist had been in the room, had gotten her on the floor and asked her to get up, and she was unable to get up. The therapist stepped out, and I walked in, and so I said, now, Ruby, you want to go home. I just saw that the physical therapist was here. They put you on the floor, and you were not able to get up. What would you do if you were at home and that happened? And Ruby told me she just banged on the floor till someone came and helped her. I said, well, that's a slam dunk. Walked out of the room thinking that we needed to look for something else. The social worker walked in the room, got a little bit more information. Ruby lived on the second floor. Her best friend lived beneath her. Her best friend was always at home, and indeed that was something they had worked on for years. She would often end up on the floor, pound on the floor with her cane. Her friend would hobble up, help her get off the floor, and that's something that they had been doing for a year. In this case, it was not the patient that didn't understand the consequences, it was more the physician. So just thinking about what you and the patients understand regarding to the consequences. So we've talked a little bit about barriers to assessment. We've talked about the ability to understand, appreciate, and reason. The last C really gets at the big picture, which is consistency. And there's several aspects to consistency. The decision that they make really needs to be consistent over time, not flip-flopping back and forth. But if they do change their mind, can they explain to you why they changed their mind? What additional information was provided that caused them to change their mind? The other aspect of consistency is that it really should be consistent with their underlying beliefs and values. So that if you're seeing someone that's refusing treatment, for example, if you look back, they've always been skeptical of physicians and healthcare professionals. They've often refused medical care in the past. They may have left against medical advice in the past or started treatments and stopped them, but a decision at the present time not to do something is really consistent with their previous behavior. Asking yourself, does the decision that this person is making make sense in light of their lifelong values and decisions? And often family and friends can help provide some insight into this. I also find that this is helpful when you're working with people, surrogate decision makers who are making decisions to the best of their abilities for someone else, really looking back at that person's beliefs and values, and is the decision that the surrogate is making consistent with those beliefs and values. To re-emphasize, the capacity is a clinical assessment of a person's ability to make a specific decision in a specific situation. It's not all or none, and an individual that's found incapable of making a decision in one area doesn't mean that they can't make it in another area. I ran into an awkward situation one time where I had a patient who was really not capable of making medical decisions, but was very capable of appointing a durable power of attorney for health affairs. She was able to tell me the names of her children. She had 2 children. She very specifically was able to state why she wanted her daughter to make medical decisions and why she did not want her son to make decisions. Also was able to tell me about other friends and relatives and why they weren't options for her. So again, she was very clear and able to appoint a durable power of attorney, but was very confused about her medical situation and not really able to participate in medical decisions. I really advocate that we look at durable powers of attorney, making them sooner rather than later and avoiding situations like that, but it is an example of a situation that you can find yourself in. Lack of capacity does not mean that a person cannot participate in decision-making at all. And certainly I work with a lot of people who have dementia, and very often with dementia, people can tell you the big picture items. I want to be at home. I don't want to live somewhere else. So if you're looking at a medical intervention that might threaten a person's ability to live at home, maybe they're best off without that intervention. The person with dementia can provide some input into that situation. There are other situations, people with delirium or who are on medications, where perhaps you can manage the delirium, stop medications, and decision-making capacity may improve over time. So really, decision-making capacity needs to take into consideration the higher degree of reasoning and understanding required for high-risk, complex decisions. An example from the financial example might be a person might be very capable to use a debit card. They might be able to manage their home finances to some extent, but I had an 86-year-old gentleman who was able to do these things, who also owned a very large business, and his ability to make the complex decisions related to that business were certainly impaired, or the ability to manage your taxes might be impaired. It's important as you approach these situations that you do your best to be objective, be aware of your own values and morals. Work hard at being objective, even if you disagree with the choices that a person makes. I've had the pleasure of working with the waiver program, or what used to be the Project Choices program, and that group of individuals have done an outstanding job keeping people at home who I never would have thought could have been at home. I was only comfortable with those situations because they did communicate with the people. They worked together as a team to empower the people, but they also developed strategies to maximize safety, put resources in place to do their best to keep them at home despite the risks. And I think this is something that we need to work towards in our practices. Finally, as you work through these issues, I think the 6 C's can be helpful in your documentation, just to prompt you in remembering those things that you need to document. I have an elderly population. Many of them are in atrial fibrillation. It seems like everyone's getting put on Coumadin or a newer medication for atrial fibrillation, but I occasionally run into a person who's very fearful of anticoagulation and simply refuses. So I can document that this is a person without hearing or vision problems. I've done my best to communicate. There are no communication barriers. I haven't identified any cultural issues. The person is aware that they have atrial fibrillation. Their medical circumstances are such that they're increased risk for stroke, and that the Coumadin may help prevent strokes. I've advised them of some of the risks. They're choosing not to go on anticoagulation. From their perspective, they've had occasional falls, and the risks outweigh the benefits. And this is a decision that's really consistent with their desire to stay at home and avoid problems. An example of how you might use the 6 C's for documenting. There are a few additional slides that I'm not going to go through, just to put in a plug for next month's Geriatric Grand Rounds, which is going to be talking about advanced care planning. Again, our Western culture favors individualism, autonomy. These are ways that you can maintain your decision making after you've lost the ability to do so. So I think with that, I will close and just see if there are any questions or comments from any of the people in the audience about medical decision making.
So we'll now open the lines for questions and comments. So please remember to state your site name first and then ask your question.
I could also provide you with my email address should you have any questions.
Okay. If we don't have any other questions or comments, we'll thank you for joining us and have a great day. Or you can always email your question directly to me, Victoria, or you can indicate it on your evaluation. Thank you, everybody, for joining us, and have a great day.
Have to do the survey.
Grayling out.